All right, so components of prenatal care. Assessment. Assessment during the prenatal period refers to the collection of medical, nutritional, obstetrical, psychological, and family histories, as well as physical assessment of the mother and fetus. Laboratory studies conducted at the initial and subsequent prenatal visit assess selected aspects of maternal and fetal health. At the onset of prenatal care, as well as affirmation of ongoing wellness and early detection of pathology, physical assessment of the mother is comprehensive and includes a physical exam, along with a detailed exam of the reproductive system at entry into the prenatal care. Episodic physical assessment occurs at subsequent prenatal visits and focuses on pregnancy related changes, overall physical well being, with special attention to potential signs of pregnancy complications. Targeted physical assessments are performed whenever there are signs and symptoms of emerging problems and coexisting disorders. Additionally, assessment of the fetus is ongoing throughout the pregnancy. Ultrasound screening is commonly performed during early pregnancy to verify viable intrauterine pregnancy, confirm or assign gestational age, assess fetal anatomy, and measure fetal growth and development. Lastly, assessment of past and current psychosocial issues, including mental health status, substance abuse, and environmental issues such as housing, socioeconomic concerns, and safety, is addressed at entry into care and at each subsequent visit. Risk assessment is integral to each prenatal encounter to evaluate the presence or absence of factors or conditions associated with adverse perinatal outcomes for the mother and the fetus. Risk assessment may also improve the quality of care of women and families and align prenatal care resources to women so that they receive the appropriate levels of care based upon their individual risk status. While risk assessment is an important component of prenatal care, there is no standardized system that accurately predicts individual risks. The evaluation of risk is confounded due to complexity of numerous variables, their interaction with each other, and the fact that some conditions may be more highly associated with adverse outcomes than others. Concentrating prenatal resources solely on women with risk factors may adversely affect women who have been deemed low risk. Other women can experience an adverse outcome without any identifiable risk factors. Some conditions, such as tobacco abuse, are well studied with known sequelae. However, not every woman who smokes experiences these adverse outcomes. Other conditions, such as maternal obesity, may be less well studied or do not have easily implemented interventions to address the identified risks. Risks that involve long-standing habits or lifestyle preferences require readiness to make behavior change on the part of women and persistent effort in creating and maintaining this behavior change. Health history. The initial visit. Ideally, the maternal history is obtained at a preconception visit so that health conditions and health behaviors that can adversely affect pregnancy are identified, discussed, and ameliorated. The expert panel on prenatal care reviewed all components of health history and reviewed the scientific evidence for the components of the health history that may impact maternal and fetal pregnancy outcomes. With few exceptions, reviewing the health history on all women at the onset of prenatal care is an important activity and is an integral component of evaluating status and planning for comprehensive care. The health history not only provides a snapshot of past and current health status, but also identifies health behavior that can negatively impact the pregnancy and can be impacted during the pregnancy. Knowledge of health history allows healthcare providers to tailor the care in pregnancy to specific health risks and educational opportunities. Pregnancy dating is an important activity during the first prenatal visit, and the menstrual history is a critical component of this assessment. Ascertaining the normal last menstrual period is the first step in determining the gestational age. The reliability of this measure can be affected by maternal recall, history of irregular menses, recent contraceptive use, lactation, or medication use. In the early 1880s, German obstetrician Dr. Franz Karl Nagel determined that the mean gestational age of human pregnancy was 280 days or 40 weeks and suggested that the estimated delivery date could be established by subtracting 3 months and adding 1 week and a year to the date of the last menstrual period. 90% of all women with known last menstrual period will deliver by the 41st week using Nagel's rule. Mean human gestation length has been estimated at ranges between 281 and 287 days, with the average being 200 days, somewhat greater than the estimate based upon Nagel's rule. Accurate dating of the pregnancy is critical to the identification of a reliable estimated date of birth. Accurately interpreting selected prenatal genetic laboratory screening, effectively caring for women who experience premature labor or post-term pregnancy, and eliminating risks associated with procedures and interventions. For example, a misstated pregnancy may erroneously indicate that a woman's pregnancy is post term and requires induction of labor. Gestational age wheels are commonly used by healthcare providers to calculate the estimated gestational age of the pregnancy. However, slight variations among wheels are common, and the wheels are based on a standard 28-day menstrual cycle. More recently, numerous electronic methods of calculating the gestational age of the pregnancy have become available. With the advent of electronic medical records, gestational age can be determined by the computer based on clinical data. Similarly, internet based applications exist that compute gestational age based upon maternal clinical data. Ultrasound is recommended when the last menstrual period is unknown or unreliable. Ultrasound fetal age estimations are a more accurate measure of gestational age when performed early in the pregnancy. The pregnancy history will identify any previous pregnancy related conditions that can impact the current pregnancy. When eliciting the pregnancy history, it is important to explore the circumstances of all pregnancy losses, gestational age at which they occurred, what precipitated the loss, and what, if any, evaluation occurred after the loss, such as genetic testing or an autopsy. This information will highlight the potential risk for chromosomal abnormalities, premature labor, or other pregnancy conditions likely to recur. Any operative procedures, such as cesarean section, should be evaluated along with the indications for the surgery, the conduct of the labor, and any complications arising from the operative intervention. A history of infertility treatments and assisted reproductive technologies can alert the provider to an increased risk of multifetal pregnancy. Sexual history provides an opportunity to evaluate risks for sexually transmitted infections and sexual practices that can continue to increase risk for the mother and the fetus. Sexual history should be elicited with a non judgmental approach and should include the following four P's. One, partner, number and gender. Health providers of partners, such as health behavior of partners, such as substance abuse, condom use, length of current sexual relationship. Practices. Sexual practices and safer sex practices will determine the woman's current risk status and can indicate need for additional screening for sexually transmitted infections. Three, protection. Are condoms regularly used? Her perception of her own risk status should be explored. Does she have concerns about exposure to STIs or partner risk factors? Previous history. Explore the history of past STIs and treatments. Does she currently have symptoms? Was her partner treated? The infection history will identify pre-existing immunity and risks for infection during the pregnancy and will also identify need for immunization during and after pregnancy. Depending on the history of childhood disease and immunization, a pregnant woman may have immunity to infections, may be at risk for infections, or may require targeted education to avoid infectious diseases during the pregnancy. Planning for postpartum immunizations will help women decrease their risk of selected infectious diseases throughout the lifespan, and particularly during future pregnancies. Family history. encompasses the evaluation for medical conditions that can place the pregnant woman at a higher risk during pregnancy and may require additional screening or evaluation during pregnancy. For example, a woman with a strong family history of diabetes may be at higher risk for diabetes or gestational diabetes and may require additional screening. An important component of family history is the genetic history. Histories that are significant for familial or hereditary diseases will alert the provider to the need for additional counseling, testing, or referral to a genetic counselor. Women should be provided with accurate information regarding personalized risks, screening, pregnancy options, benefits and harms of testing options, and many potential outcomes related to particular genetic problems. While genetic issues can be complex, all prenatal care providers should be able to discuss basic genetic counseling and testing and to perform a basic 3 generation pedigree with genetic history. Numerous resources exist for healthcare providers to become more proficient regarding the genetic components of prenatal care, such as the March of Dimes and the International Society of Nurses in Genetics. Nutritional history not only provides an assessment of the current diet and nutritional status of a pregnant woman, but also identifies areas of dietary deficiencies that may be amenable to interventions. For example, um, s- uh, sufficient intake of folic acid during the preconceptional period reduces the incidence of neural tube defects. The nutritional history also identifies dietary practices that can impact the pregnancy. For example, women who eat a vegan diet may require information about additional sources of proteins, vitamins, and minerals to meet recommended allowances for pregnancy. Women who report consuming foods that can negatively impact pregnancy, such as eating certain fish species, raw meat, or certain cheeses, may be at increased risk for exposure to toxins or infectious diseases and need targeted information to make necessary dietary changes. A review of maternal diet can also indicate the need to supplement the diet with vitamins and minerals. Guidelines from the USPHTF as well as the IOM outline dietary recommendations for pregnant women based on age. The psychosocial history explores the life and work concerns of a pregnant woman and can highlight areas for support, education, and additional resources. Stress and lack of social support can impact pregnancy outcomes, so it is important to elicit the woman's perception of stress, her coping mechanisms, as well as her support system. This is accomplished through dialogue and open ended questioning throughout the pregnancies. Tools can be used quantitatively to measure stress and coping. Perceived stress can result from many aspects of life, such as family, work, or relationships. Financial concerns can also lead to additional stressors, such as housing and basic resources like food. The psychosocial history will provide direction for targeted resources that may be needed. It is not uncommon for multiple resources. It is not uncommon for prenatal care providers to become familiar with community resources and agencies that provide necessary services to women during pregnancy. The expert panel recommended that the psychosocial history take place at the initial visit and then regularly updated each subsequent prenatal visit. Health history, subsequent visit. At each subsequent visit, the prenatal care provider should assess the woman's signs and symptoms associated with common pregnancy problems. Changes in lifestyle, circumstances, exposures, and recent illness should also be assessed. Prior to term, symptoms of premature labor, vaginal bleeding, or leakage of amniotic fluid should be assessed at each visit. Common pregnancy changes and discomforts should be explored. A review of the psychosocial history should be completed with special attention to violence, depression, and substance use if applicable. Physical assessment. The initial visit. A general physical examination should be conducted on all women at the first prenatal visit. Since pregnancy affects all body systems, each system should be evaluated and the findings recorded. Um, Measuring the height and weight on all women is beneficial along with calculation of the body mass index. Pre-pregnancy weight is important as it will guide the recommendations for weight gain during pregnancy. Blood pressure, pulse, and respiration should be measured on all women at the initial visit. A pelvic exam to assess for uterine size is especially important in early pregnancy before 12 to 14 weeks and can help in confirming gestational age. Mm, Clinical pelvimetry, although commonly done at the initial visit, was studied by the expert panel and was found to have poor evidence supporting its efficacy. However, it may be useful to assess pelvic adequacy in late pregnancy or during labor. Auscultation of the fetal heart sounds with a handheld Doppler ultrasound device can begin at 11 to 12 weeks of gestation. Although the heart sounds may be heard earlier depending on maternal habitus and the position of the uterus. Assessment of the location of the fundal height can begin when the uterus becomes an abdominal organ, sometimes after the 12th week of pregnancy. The measurement of the fundal height provides information regarding the growing uterus. However, its accuracy is limited by the skill of the practitioner. Maternal characteristics, such as status of the maternal bladder or abdominal adiposity, and the angle of the examination table. The most common way to measure fundal height is to place a tape measure on the superior border of the symphysis pubis and to bring the tape measure across the contour of the maternal abdomen in the midline to the top of the fundus. Using this method, the centimeters should approximately equal the weeks of gestation after 20 weeks gestation. Subsequent visits. At each subsequent visit, maternal blood pressure and weight should be obtained. Weight gain since the last visit and since the onset of pregnancy can inform the woman and her provider about the adequacy and pattern of weight gain. Fundal height in centimeters is measured at each visit, along with locating and counting the fetal heart rate. Assessment of maternal perception of fetal movement usually begins in the second trimester and is determined at each visit. Auscultation of the fetal heart rate using a handheld Doppler ultrasound device can begin as early as 11 weeks and at 16 to 20 weeks if using a fetoscope. Expert panel on the content of beginning at the third trimester. Leopold's maneuvers are performed. These maneuvers are a series of abdominal examinations that can help the prenatal care provider determine the fetal lie, presentation, position, and engagement of the fetal presenting part into the pelvis. The abdominal exam can also assist the healthcare provider in estimating the fetal weight. Routine cervical examinations is not recommended until the 41st week of pregnancy by the expert panel, but may be appropriate earlier in women at risk for premature labor. The expert panel found insufficient evidence to recommend routine urine screening for protein and glucose at each prenatal visit in the absence of symptoms of preeclampsia or infection. Laboratory. Routine laboratory studies were evaluated by the expert panel, and most of these tests were found to be important component to prenatal care and risk assessment. Routine laboratory diagnosis of anemia, certain infection, and determination of the Rh factor subsequent to the expert panel recommendations for additional laboratory studies have been suggested due to new evidence of their association with improved pregnancy outcomes. Numerous organizations and professional organizations contribute to the recommendations for laboratory testing during pregnancy. Not all types of testing are available to a woman due to geographic location, financial resources, or site of care. Current recommendations for routine laboratory studies and the appropriate timing are found in Figure 5.5. Genetic testing. All right, we're going to, the hemoglobin and hematocrit should be tested in the all woman, blood type and Rh factor, all woman, and these are all for all women. Urine dipsticks and glucose. Tuberculosis is done in some women. Gonorrhea and chlamydia are tested at women that are 25 or younger or those that are at high risk. Syphilis is done on all women. Urine culture for asymptomatic bacteriuria is done on all women. Hepatitis B is done on all women. HIV is done on all women, and there's an opt-out option for that. Pap smear is done at age 21 and over every 1 to 3 years, depending upon the age and past screening. Herpes is done on selected populations, varicella on selected population, hema- hemoglobinopathies are done in selected populations, toxoplasmosis on selected populations, illicit drug screen is done if offered. Oh, it's done on all patients. Trisomy 21 or 18 and 18 is uh is offered to all women. Neurotube defect is offered to a woman. Hemoglobinopathies for sickle cell disease is done in African American and African descent is offered. Hemoglobinopathies for thalassemia is done on South East Asians, Mediterranean, and Hispanics. And cystic fibrosis is offered to all women who have a carrier screening. Tay-Sachs disease is done to the Ashkenazi Jewish, Cajun, and French Canadians. Canavan's disease is offered to Ashkenazi Jewish, and familial dysautonomia is offered to the Ashkenazi Jewish. All right. So, genetic screening. Prenatal genetic screening has expanded significantly since the expert panel reviewed the scientific literature. Some genetic screening is routinely offered to all women, while other tests are offered to selected group based on racial and ethnic heritage, age, or other risk factors. All discussions regarding genetic testing should be based upon the principles of shared decision making with the woman and her family. Informed consent is necessary to ensure that pregnant woman understands the voluntary nature of genetic testing, the purpose of the test, limitations of the test, and what she will do with the information and what the implications are for herself, her baby, her future pregnancies. Prenatal genetic testing is reviewed more in detail in Chapter 9. Diagnostic testing. Diagnostic testing in prenatal care was not evaluated by the expert panel. However, the use of diagnostic testing has increased significantly over the last decade. Ultrasound is the most commonly used diagnostic test in pregnancy and can provide information about many normal events as well as abnormal processes. First trimester ultrasound is an accurate way to confirm the viability of a intrauterine pregnancy with the identification of a fetus with cardiac activity and confirm that the pregnancy is implanted in the uterus instead of an extrauterine site. A frequent use of ultrasound is the confirmation of gestational age. It can also be used to accurately estimate gestational age and establish an EDD in the absence of a reliable last menstrual period. Ultrasound also plays a role in genetic screening with the evaluation of nucleotranslucency. Specially trained personnel can measure the neck of the fetus and identify abnormalities when coupled with genetic serum screening. Ultrasound can identify a fetal at risk for several trisomies, allowing earlier diagnosis than other available methods. After the first trimester, ultrasound can be used as a screening exam for structural abnormalities at 18 to 20 weeks of gestation. Ultrasound can also play a role in evaluating the fetal anatomy, placental position, implantation, amniotic fluid volume, and fetal growth as needed by the clinical indications. Abnormalities identified on standard ultrasound may require additional information such as fetal echocardiogram to more closely examine the structure and function of the fetal heart. Doppler studies can evaluate the placental blood flow and abnormalities, which may indicate a compromised blood flow to the placenta and fetus. Fetal well being may also be evaluated with ultrasound by using the biophysical profile. The purpose of an antenatal surveillance of the fetus is to identify pregnancy risk for stillbirth, decrease the risk for intrauterine fetal demise, and prevent unnecessary intervention in pregnancies in which there is no benefit to the cessation of the pregnancy through intervention. Increased risk to the fetus is identified through the maternal history, such as previous fetal demise, maternal conditions such as hypertension, reports of decreased maternal perception of fetal movement, or a prolonged pregnancy. The assessment of fetal well being is reviewed in detail in Chapter 10. Preventive care. Prenatal care is a form of preventive care in many respects. Goals include prevention of adverse pregnancy outcomes through the identification of risk factors, treatment of ongoing health issues, and utilization of health education and preventive health practices to adjust to pregnancy changes and prepare for a new baby. Most preventative care focuses on maternal care needs but can provide for improved health outcomes for infants as well. One such example is immunizations. Immunizations is not only to provide immunity for women for vaccine preventable illnesses, but can provide passive immunity for the newborn. Well, the most opportune time to evaluate for the immunization needs of a woman is during the preconception period. Many vaccines are safe to administer during pregnancy and are recommended to promote optimal maternal health. Live virus vaccines are contraindicated during pregnancy but can be given in the immediate postpartum period, even if breastfeeding. The CDC maintains the most current listing of recommended immunizations for women during and after pregnancy. Oral health. Recent evidence suggests that poor oral health may increase risk for preterm delivery. Periodontal disease has been identified as an independent risk factor for preterm labor. Encouraging good oral health, including regular brushing and flossing, as well as cleaning and treatment of dental caries, is an important preventive health practice during pregnancy. Women should be encouraged to visit the dentist early in pregnancy. During pregnancy, it is safe to receive shielded dental x rays, have local anesthesia if needed, and to use antibiotics that are safe in pregnancy as needed for dental procedures. Tetracycline and related antibiotics should never be used during pregnancy as they can cause permanent tooth staining in infants exposed during pregnancy. Pregnant women may notice that their gums can bleed more easily during regular toothbrushing, and this observation can prompt questioning regarding oral health during regular prenatal visits. Mental health. Mental health issues are an important component of the prenatal care. Maternal stress has been linked to prematurity as well as poor infant health outcomes. A woman's ability to cope with the changes related to pregnancy, transition, parenthood, and new motherhood will directly impact her health as well as her new baby. In the last decade, it has been recognized that depression throughout the prenatal period is more common than originally thought and contributes to morbidity and mortality for childbearing families. Major depression during pregnancy and up to 6 months postpartum affects 10 to 15% of all childbearing women. Screening of all women during pregnancy as well as the postpartum period is a now recommended. Is now recommended. There are a number of tools developed to measure depression, some specifically during the perinatal period. These include the Edinburgh Postnatal Depression Scale and the Postpartum Depression Screening Scale. Um, Other scales used during the perinatal period but designed for use with the general population include the Back Depression Inventory, the Centers for Epidemiological Studies Depression, and the Patient Health Questionnaire. Regardless of the screening tool used, all women should have screening done at least once during the pregnancy and once in the postpartum period. Scores indicating depression should be shared with women, and referrals for mental health services should be offered when indicated. While there is controversy about treatment modalities due to safety concerns in pregnancy for some medications, some women with significant depression may require pharmacological treatment as well as individual or group counseling. Intimate partner violence. IPV includes physical, sexual, or psychological harm by a current or former partner or spouse and affects women of all races and ethnicities and all socioeconomic groups. Violence against women can escalate during pregnancy, making women more vulnerable to both physical and psychological abuse. It is recommended that all women be screened for IPV during the first prenatal visit and once each trimester or whenever IPV is suspected based on history of physical examination. A brief set of questions has been used successfully to assist prenatal providers in identifying women who may be experiencing IPV. In the last year, have you been hit? slapped, kicked, or physically hurt by someone? Since you have been pregnant, have you been hit, slapped, kicked, or physically hurt by someone? Has anyone ever forced you to have sex with them? And are you afraid of your partner or anyone else? These questions should be asked in private without a partner present, and if positive responses are elicited, further evaluation is required. The prenatal care provider can provide a safe environment to explore the issues, reassure that this abuse is not her fault, and assess her for current and future safety. IPV is a complex situation, and leaving an abusive partner may not be immediately feasible or preferred by the woman. Referrals to local sources are critical, including counseling and shelter. Health promotion education. Perhaps there's no other time in a woman's life where she will have the unique motivation for making health behavior changes as during pregnancy. It is also a time when health behavior changes have the most impact by improving maternal health, creating healthier environment for a developing fetus, and setting the stage for maintenance of healthy behaviors after pregnancy. When the expert panel reviewed the evidence regarding the health promotion topics with a positive effect on maternal and neonatal outcomes, nutrition and smoking cessation were found to be the two most likely behaviors to improve with counseling. Nutrition. Nutritional information during pregnancy includes not only dietary information regarding calorie needs, vitamin and mineral requirements, and food safety, but also information on appropriate weight gain during pregnancy. During pregnancy, the energy needs of women increase, especially in the second and third trimester. Protein intake needs increase by about 20%, and most vitamin and mineral needs increase, some significantly. For example, iron, folic acid, and vitamin D needs double during pregnancy, while a well balanced diet can meet most of the increased dietary requirements. It is fairly common for women to take a prenatal vitamin and mineral supplement. Optimally, this supplement will begin in the preconception period to provide adequate folic acid intake at the time of conception. Women who present with pre existing nutritional deficiencies, such as iron deficiency anemia, may need additional supplementation. This nutritional assessment begins with a discussion regarding the woman's typical diet, cultural food preferences, special dietary practices, and food resources. The healthcare provider should provide nutritional information so that the woman understands the increased dietary needs of pregnancy. For example, the calcium needs during pregnancy significantly increase, so identifying dietary sources of calcium will allow women to alter their diets. Similarly, as iron deficiency is common during women of childbearing age, providing information regarding foods that have high iron content will be helpful. Food safety is important during pregnancy as it can prevent transmission of foodborne illnesses that can cause poor maternal and fetal outcomes. A common way to evaluate maternal nutritional status is by calculation of the BMI. In 2010, the IOM revised guidelines that tailor recommendations for weight gain during pregnancy for the maternal BMI and nutritional status at the onset of pregnancy. In resource poor countries, maternal nutrition is commonly focused upon increasing maternal calories and supplementation due to poor food resources and food quality. However, in the United States, it is more common for a woman to begin her pregnancy overweight or obese, thereby increasing her risk of complications. Similarly, women may gain more than the recommended weight during pregnancy, which increases their risk for pregnancy complications and chronic illnesses. General nutrition guidelines for all women during pregnancy include the following: eat a wide variety of foods. A well balanced diet will help to meet all the daily requirements. Increase foods that are high in fiber, such as fruit, vegetables, and foods made with whole grains. Eat 3 meals per day with healthy snacks in between the meals. Uh, Drink 8 glasses of water per day. That's 64 ounces at least. Gain the recommended amount of weight. Use supplements if needed. Avoid foods that may increase risk for the mother and the baby. Prepare foods safely. The United States Department of Agriculture sponsors for the woman, infant, and children nutrition program. This program provides supplemental nutrition for pregnant and lactating women, allowing for the addition of healthy foods to meet the needs for increased protein, calcium, fiber, and calories in low income women. Women who qualify for this program should be directed to enroll in services. Maternal nutrition during pregnancy is covered in future details in Chapter 6. Substance abuse. Cultural relationships and genetics all play a significant role in exploring substance abuse among pregnant women. Among pregnant women. Um, While women report a lower incidence of substance abuse than men, once initiated, women are just as likely to develop substance abuse disorders. Women are more relationship oriented and are more likely to abuse substances if their partner is a substance abuser or if they have a past history of trauma or abuse. During pregnancy, it is possible that women may reduce or abstain from addictive substances. However, if they are unwilling or unable, serious consequences may ensue due to the fetal and maternal effects of tobacco, alcohol, or illicit substances. Additionally, substance abuse is often underreported by women, particularly for fears related to custody. Overall, how substance abuse affects the woman and her pregnancy will depend on the type of substance or substances used, how long and how frequently she uses the substance, and what, if any, comorbidities are present. For example, women who drink alcohol are also more likely to smoke cigarettes. Mental health issues can coexist with substance use and should be assessed by the healthcare provider. Tobacco use. Experts will agree that there is a benefit to counseling pregnant women about the risks of smoking and that smoking cessation programs during pregnancy can decrease the incidence of premature labor and low birth weight infants. Public health service. Um, oh, hold on. The adverse effects of smoking in pregnancy are well documented and include an increased risk of ectopic pregnancy, spontaneous abortion, low birth weight, abruption placenta, placenta previa, and prematurity. The toxic chemicals in cigarettes, as well as carbon monoxide, are thought to be responsible for a lack of oxygen in the fetus, as well as neurobehavioral and cognitive effects frequently observed in the children of women who smoke during their pregnancy. Smoking cessation programs can be effective in pregnancy as women are usually highly motivated to change behaviors that are linked to poor health outcomes in their infants. However, tobacco addiction is difficult to overcome and the relapse rate is high after pregnancy. Many resources exist to assist prenatal providers to help their patients to quit smoking during pregnancy. Each state has a telephone quit line that links women to resources for quitting, including access to printed materials, support from telephone counselors, and information about the prevention of relapse. Healthcare providers should give the national quit line number now 1-800 quit now to a woman who smoked during pregnancy. While not all states offer all services, those with access to telephone-based counseling have been shown to be more effective. Additionally, there are many quit smoking websites and applications for mobile devices that can be used as cessation aids. Targeted and effective smoking cessation counseling can and should occur during prenatal care. ACOG and CDC have developed a self-instructional educational program and toolkits that provide information and support regarding effective counseling techniques. The 5A's is one such program that is effective in counseling women regarding smoking cessation during pregnancy. 5A's of smoking cessation. Ask. Always ask women about their current smoking status at each visit. Advice. Advise a woman to quit smoking and provide information about the health and economic benefits for quitting for her, her baby, and her family. Assess. Assess whether the woman is willing to make a quit attempt in the next 30 days. Assist. Assist the woman with her quit attempt by providing information and resources for smoking cessation and referrals to smoking cessation and quit lines. Arrange. Arrange to follow up with the woman within a week of her planned quit attempt. Follow on her progress at each visit and offer continued support, information, and other resources as needed. Currently, there is insufficient evidence to suggest that pharmacotherapies are effective and safe for use in pregnancy. It is not recommended that nicotine replacement products or antidepressants be used as therapies for smoking cessation during pregnancy. Alternative therapies, such as meditation, hypnosis, acupuncture, have been used with some success in smoking cessation. While there is insufficient evidence for the effectiveness of these alternative therapies, there are thought to be fewer risks with their use. Alcohol, alcohol use. Alcohol has been associated with a number of adverse pregnancy outcomes. The CDC estimates that 1 out of 8 women consume some alcohol while pregnant, and that each year 40,000 babies are born affected by fetal alcohol spectrum disorder. Women who consume alcohol regularly during pregnancy are at increased risk for spontaneous abortions, abrupted placenta, and infection. Similarly, the fetus is at increased risk for low birth weight, intrauterine growth restriction, and congenital anomalies, preterm birth, and neonatal depression. And alcohol related birth defects, ARBDs, are syndromes incorporating a wide range of findings consistent with maternal alcohol use. No safe amount of alcohol has been determined. Therefore, women should be advised to abstain from alcohol use during pregnancy. Alcohol dependence can develop with regular use, making it difficult for women to stop drinking without assistance from prenatal care providers and mental health specialists, helping women identify that they may have an um, an alcohol problem is the first step in addressing alcohol dependence in pregnancy. The TACE questionnaire is a tool specially for women who can help them identify alcohol related problems. TACE questionnaire. T, tolerance. How many drinks does it take you to make you feel high? Greater than 2 drinks is 2 points. Annoyed. Have people annoyed you by criticizing your drinking? Yes is a 1 point. Cut down. Have you ever felt you ought to cut down on your drinking? Yes is 1 point. An eye opener. Have you ever had a drink first thing in the morning to steady your nerves or get rid of a hangover? Yes would be 1 point. A score of 2 or greater indicates the need for further assessment and referral. Alternatively, the National Center for Alcohol Use and Alcoholism suggests that women that are at risk for alcohol-related problems, if they consume more than 7 drinks per week or more than 3 drinks per occasion, on any drinking by women who are pregnant or may become pregnant during pregnancy, women who report that they are unable to stop drinking should be offered a referral to a substance abuse treatment provider or facility. Illicit drugs. Addressing substance abuse during pregnancy can have a positive effect on maternal and fetal outcomes. Drugs of abuse present special challenges for women in pregnancy. Not only do most illicit drugs have significant effects on the developing fetus and increased risk for low birth weight and prematurity, the illegal nature of the substances also places the woman at risk for difficulties with law enforcement. In some states, pregnant women who abuse legal drugs can be detained or can face custody issues after the birth if an infant tests positive for illicit drugs. In some states, during testing, drug testing is mandatory during pregnancy and providers can be required to report documented substance abuse. It is incumbent upon the healthcare provider to know the laws of the state regarding testing and reporting of women who may be suffering from a substance abuse disorder. Screening for drugs of abuse during pregnancy is a complicated issue as women may not want to admit they are using drugs due to illegality or understand negative consequences related to admitting to substance abuse. Similarly, they may be under the influence of an addictive substance and fear the effects of withdrawal or may not be at a point where they can readily seek help, even though they may understand the risk to themselves and the baby. All women should be screened for substance abuse in pregnancy, although there is no consensus as to which modality for screening is most effective. There is some evidence that self report questionnaires may elicit more accurate information than face to face interviews. Screening identifies women who may um, require more thorough assessment for addictive disorder. A common screening tool for substance use is the 5 Ps. There is a correlation between smoking and substance abuse. And women are more likely to abuse drugs and alcohol during pregnancy. If they smoke in the month prior to pregnancy, a yes response to an item of the 5 Ps suggests is a need for more thorough assessment. The 5P screening tool for substance abuse. Peers. Do any of your friends have a problem with drug or alcohol use? Partner. Does your partner have a problem with alcohol or drug use? Parents. Did either of your parents have a problem with drug or alcohol use? Past use. Before you knew you were pregnant, how often did you drink beer, wine, coolers, or any liquor? Not at all, rarely, sometimes, or frequently. Present use. In the past month, how often did you drink beer, wine coolers, or liquor? If not at all, rarely, sometimes, or frequently. Smoke. How many cigarettes did you smoke in the month prior to pregnancy? Currently, routine toxicology screening is not recommended for pregnant women. However, certain maternal behaviors and pregnancy complications are often associated with substance use and can alert that further evaluation is warranted. Women with late entry into care, lack of compliance with scheduled visits, or no prenatal care can indicate substance abuse. Preterm labor, placental abrasion, precipitous labor, unexplained stillbirth, and intrauterine growth restriction have all been linked to substance abuse. If testing is warranted, the woman should be informed, but in most states, consent is not required. However, the clinician should understand that ethically the woman has a right to this information as well as a right to refuse such testing. Coercive or punitive strategies for unacceptable maternal behaviors deny a woman's right to privacy and bodily integrity are not the best interest of helping the woman and her baby. Testing can be accomplished through urine screening, hair analysis, or by testing the infant. However, accuracy of results depend upon the drug drug used and the timing of the last administration. Center for Women who are unable to discontinue substance use during pregnancy will need intensive treatment, most likely as an important inpatient, although there are few residential treatment centers that accept pregnant women. Certain drugs of abuse, like heroin, are highly addictive and require careful detoxification to prevent maternal fetal complications. Depending on what substances are used during pregnancy, some infants will require detoxification after birth and require extended hospitalizations. Prenatal care provides a unique opportunity to provide services and support to women who have addictive disorders. Women during pregnancy are often highly motivated to change unhealthy behaviors and want to do what's best for themselves and their infants. Further information about substance abuse during pregnancy is provided in Chapter 13. Exercise. Exercise in pregnancy is encouraged and can assist women to achieve healthy weight gain goals and benefits, overall health and well-being. While all women can benefit from moderate exercise for 30 minutes each day, some activities may increase risk to the mother and the fetus and should be avoided. Exercises that has risk for falling, and abdominal trauma, or high impact sports should be avoided. Exercise patterns may change as the pregnancy progresses, and the enlarging abdomen will necessitate alterations in routine exercise programs. Women should be encouraged to listen to their bodies and discontinue or decrease exercise intensity if they begin to experience any of the following: vaginal bleeding, dyspnea prior to exertion, dizziness, headaches, chest pain, muscle weakness, cough, pain, or swelling, preterm labor, decreased fetal movement, amniotic fluid leakage. While these recommendations apply to most pregnant women, some women may be counseled to avoid exercise during pregnancy. More detailed information on exercise during pregnancy is provided in Chapter 5. Working in pregnancy. Women throughout the world routinely work during pregnancy. For the majority of women, there are few risks for adverse health outcomes from continuing work during pregnancy, and there can be benefits of working. However, certain workplaces or occupations may pose risks or may require certain accommodations during pregnancy. There's a wide range of potential exposures to workplace substances and their effects on pregnancy and reproductive outcomes. Women who may be exposed to hazardous chemical cytotoxic drug, ionizing radiation, or minerals like lead need to consult their workplace for evaluation of potential exposures to determine whether it is safe to continue to work in these areas. Maternal safety data sheets are documents containing information and instructions on hazardous materials present in the workplace. MSDS contain detail about hazards and handling and risk-related events to substances, requirements for safe handling, and actions to be taken in the event of fire, spill, or overexposure. It should be noted, however, that few of these substances will have data on effects during pregnancy, so a cautious approach is indicated. The Occupational Safety and Health Administration requires that this information is available at the workplace. OSHA is an excellent resource for workers and providers and can assist in determining workplace during um, workplace risks during pregnancy. The type of work performed, hours worked, and workplace environment all can contribute to a woman's tolerance of work throughout the pregnancy. Women who work in jobs which require which is repetitive lifting, climbing, stooping, or bending should have their work duties evaluated for continued safety throughout the pregnancy. In 1984, the American Medical Association developed recommendations for limiting certain types of work activities. Mm, during pregnancy, which included limiting repetitive bending, climbing, or heavy lifting, more than 23 kilograms, and limiting standing to no more than 30 minutes uh, per hour at 32 weeks. However, occupations vary a great deal in terms of required activities and will need to be considered on an individual basis for recommendations regarding continuation, alteration, or discontinuation of that specific job. Some women will want to stop working prior to the onset of labor due to fatigue and difficulty with the physical demands of advancing gestation. It is common that women can be considered eligible for pregnancy leave at 38 weeks gestation. In the United States, women do not enjoy generous paid maternity benefits and often have short periods of paid leave or no leave at all. The FMLA was enacted in 1993 and provides for women during pregnancy. The Pregnancy Discrimination Act prohibits discrimination based on pregnancy when it becomes when it comes to any aspect of employment, including hiring, firing, pay, job assignments, promotions, layoff, training, fringe benefits, and such as leave and health insurance, and other and any other term or condition of employment. Pregnant women who experience a medical complication related to pregnancy must be treated as any other employee with a short-term disability and must be offered light duty, alternate assignments, or disability leave. Health education during pregnancy. Health education during pregnancy is important for maternal and health psychosocial well-being and helps to prepare for transitions to parenthood. The challenge in prenatal care is how to incorporate the necessary health education with ongoing physical and risk assessment with the prevailing prenatal care system. Health education may not be a priority or it is limited due to the time constraints of prenatal care providers, while women who attend centering pregnancy groups have extensive health education as a major component of prenatal care. Women in traditional individual care will need additional resources to meet their ongoing educational needs in order to obtain in depth and comprehensive health education, it may be necessary for women to attend classes outside of their regularly scheduled visits or to seek outside resources such as books and online resources. Prenatal care providers should be familiar with the common consumer resources for their clients. The expert look at resources for women and families. The expert panel recommended that health promotion content be provided based upon the needs of women throughout the pregnancy. Early pregnancy concerns will be different from those at the end of pregnancy. Anticipatory guidance is critical so that women will know what to expect at each stage of pregnancy. This will help them to identify common changes and discomforts and alert them to danger signs that may indicate the need for evaluation. Preparing for labor and birth and early parenting is important to help promote a successful transition to parenthood and ensure that women have appropriate resources and information. Health education during pregnancy is reviewed in Chapter 17. Summary. Prenatal care has the potential to affect the health of woman, her infant, and her family in a positive way. Current trends in healthcare emphasize the importance of evidence based care to achieve improved health outcomes. Pregnancy and childbirth represent one of the largest expenditures of healthcare dollars for both public and private insurers. Yet, despite this significant expenditure, the United States ranks well below other developed and some developing countries in maternal and child health outcomes. Recent efforts, like the Transforming Maternity Care movement, have identified that the current system of maternity care is procedure intensive and costly, and that the overuse is contributing to excessive harms and cost. Conversely, preventative care is underused and misunderstood by many prenatal care providers. Significant disparities exist in maternal and infant outcomes, and little to no progress in improving outcomes has been made despite significant expenditure. Lastly, childbearing women lack choice in their healthcare provider, place of birth, and childbirth experience due to institutional policies, reimbursement issues, and provider availability and preferences. Prenatal care providers have a unique opportunity to change how women and families experience pregnancy and birth. Transforming Maternity Care is a group of over 100 experts in maternity care and health policy brought together to create a blueprint for achieving a safer, cost effective, and woman centered prenatal care system. They recommend the following. Each woman is engaged as a partner in her own care and education during pregnancy. She receives affirmation and practical support for her role as the natural leader of her care team to the extent that she so desires and is encouraged to provide input to shape her own care. Each woman's preferences are known, respected, and matched with individually tailored care that meets her needs and reflects her choices during pregnancy, delivered by a care team whose composition is also customized based on her needs and preferences. Each woman has access to complete, accurate, up to date, high quality information, decision support, and education to help ensure that she feels emotionally and psychologically prepared to make decisions during her pregnancy and confident about her birth options and choices well in advance of the onset of labor. Education and care during pregnancy are designed and delivered to be empowering for women, emphasizing a climate of confidence. Education and care during pregnancy includes support for breastfeeding. Most women make decisions about infant feeding well before they give birth. Each pregnant woman receives personalized coaching and has access to high quality resources for comprehensive health promotion, disease prevention, and improved nutrition and exercise for optimal wellness during her pregnancy. 7. Care during pregnancy is available when needed and can be accessed in a time and place that is convenient and accessible for each woman and balanced with concerns for value and efficacy. Care during pregnancy acknowledges the social context in which pregnancy occurs for each woman and includes opportunities for social networking and access to adequate professional and peer support during pregnancy. These changes may not be easy, but are necessary to improve the health of families and communities. Prenatal care is over 100 years old, with many traditional aspects that remain important today, but it's time to integrate the current evidence into the best care practices for women and families throughout pregnancy and birth. Let's see immunizations, pregnancy, real quick here on page um, 89. Vaccines help keep a pregnant woman and her growing family healthy. And this is immunizations and pregnancy available from the CDC. So, before pregnancy, we should have hepatitis A and hepatitis B vaccine. We should also have HPV vaccine if you're between ages of 9 through 26 years of age, influenza TIV also, influenza LAIV if you're less than 50 years old and healthy, and avoid conception for 4 weeks after you get that vaccine. Um, let's see. MMR should be given before pregnancy. Meningococcal polysaccharide, if indicated before pregnancy. Tdap should be given, and Tdap and varicella also should be given. And you should avoid conception for 4 weeks after you get the varicella vaccine. All right. Yeah, that's the end of that. Page 96.